So I would like to welcome Dr. McCann as we dive deeper into the topic of fear avoidance within the athletic population. Many athletes can experience injuries but are unable to return to play at their full potential and even face the risk of re-injuring themselves. This is a topic that has been of specific interest to me as I've had a lot of experiences through my own clinical experience. And so I've noticed that sometimes the topic of fear avoidance can be forgotten or even neglected. There are various questions that I'm going to discuss in here. And so I welcome you to share your expertise and knowledge based on what you have experienced as well.
Sure.
So the first question to start it off is, how valid do you feel the fear avoidance model questionnaire is?
Yeah, fear avoidance has been studied for a while now. Going back probably around 20 years, it's been pretty popular within the sports medicine research, and it's been validated pretty extensively. It's been published now in multiple languages, and it's been studied in multiple patient populations, and it's been validated across many of those in many different forms of validity too. I think looking at it personally, I think it has face validity in that you look at it and it's clearly asking about those concepts of fear avoidance. I think the content validity that has been sent to multiple experts, whether it's athletic trainers, physiotherapists, physical therapists, physicians, all of these different types of clinicians have looked at this instrument and agreed that it has been a worthwhile instrument to include. And then some of the construct validity too. There's been correlational studies looking at it compared to other patient reported outcomes, whether they're region specific, the more generic patient reported outcomes. We see some consistency between those. So we know that they're both sort of these measures of health related quality of life. And then we've even looked at validation of fear avoidance with other similar instruments like TAMP scale of kinesiophobia. So we've seen some consistencies between those instruments too, and I think all of that information collectively really helps indicate that fear avoidance is a valid questionnaire. And then even to build on that too, beyond just the validity, we've also seen very good consistency. So that speaks to the reliability of the instrument, where the retest reliability, if we give a patient the instrument, at time instance 1, and then we come back the next day and we do it again, we're getting very consistent scores. So that's also a very good psychometric property for that to hold.
Thank you. How do you feel about the subjective matter of this questionnaire, in the sense that different athletes might have different pressures that are impacting their answers, or those who may actually, we have a lot of athletes here who are going into medical field or athletic training, and they've already heard of this. Do you think that can impact the way they answer the questions based on how quickly they want to get back, or they think if they answer a certain way, it might impact the outcome?
Yeah, I think it can have an effect. I think there's definitely going to be athletes out there who are looking for any advantage to get that return to play clearance as fast as they can. And those do exist. It can be hard, and I don't know that I was ever the best at doing it, of trying to figure out who's being strictly honest with me. I think for the most part, in my experience, I think athletes and patients are honest and want the best for themselves. You will, no question, have some of those individuals who will do anything to get by. But, my approach to that has always been talk to your patients and indicate to them that it's a two-way street. I'm here to help my patient get back to the optimal level that we can, but I need them to meet me halfway. And if I can't trust that individual, if they're not going to be honest with me, it's going to be very difficult for me to achieve those goals with the patient. So I think explaining that from the get-go, regardless of what your clinical goals are, what their objectives are, I think setting those ground rules that, I can help you, but I need you to help me help you, right? I think that's so important for any patient of any type working with any type of clinician. I don't know that the fear avoidance beliefs questionnaire has any uniqueness to it in that regard. If people are more, likely to, be dishonest about it, I think that, I've talked with some patients before who look at it and they think it's kind of silly. They think some of the constructs that we're trying to measure, they're not really interested in them. It's a little too kumbaya for them, but, explaining to them again that, hey, this is valuable. This gives us important pieces of information. I think that helps them with the buy-in for it.
Yes, I agree with that. Next question was just, do you feel that athletic trainers who are more further in their career focus on fear avoidance, or do you think it's more of a focus that is common among newer graduates that are into the profession now that kind of focus a little bit more on thinking about how that can impact re-injury, or are just focused on structured function in that sense?
Yeah, I'm not really entirely sure. My mind kind of goes two different directions with this question. On one instance, since the fear avoidance beliefs has been such a hot topic in the last 15, 20 years, it leads me to think that it's probably being taught in curriculum more frequently nowadays versus when, maybe when I went to school a while ago. I don't remember ever hearing about fear avoidance beliefs when I was an athletic training student or a master's student. So in that regard, it makes me think that maybe it's the younger ATs who are more on top of this sort of thing. That being said, there are some other data that are sort of indirectly related to this, and maybe not so much age. Some of the work that we've done related to ankle sprains and who's using patient-reported outcomes, we've actually found that athletic trainers with a higher level of education and more familiarity with expert guidelines, those are the people more likely to use patient-reported outcomes. So it's not necessarily older versus younger as much as it is who's got the more advanced education and who's staying on top of the literature. Those seem to be the individuals who are using the best practice guidelines.
That makes sense. Yeah, because one of the things, the reason I came to this question was through various preceptors I've had, it's been more of the younger ones who are more focused on, like, look at this study, look at what I found in the literature, who have been focused on fear avoidance. One example that comes to mind is there was a soccer athlete who had a minor injury that was almost never really diagnosed of what it was. It was just kind of mid-foot pain. And it was just reoccurring. It was senior year and felt like they couldn't get past it. And going into rehab, trying to get them back, and then throwing the soccer ball back in. It was like, oh, I'm scared to do that. And hearing that, and then being able to talk with my preceptor and actually think about, okay, this is where fear avoidance is coming in, as compared to, some other preceptors who never really went that route when they were thinking of, why is my athlete not getting better? Why do they not want to go to practice today? Things like that. So that's kind of where I've seen it in my experiences so far. So I definitely get where you're saying.
Yeah, and I think that we can dive into these questions a little bit more. I know, some of these patient-reported outcomes are a little bit vague. It's really hard to touch on all the nuance of, an individual patient. And I think there's a lot of, reason that we should not just take the score at its face value. But if a patient's answering a patient-reported outcome in a certain way, ask follow-up questions with that patient. And I think that you can dive in deep and get an understanding of what specific activities are causing that fear. What exactly are patients avoiding? And I know that from my own experience of being somebody who has, I always go back to ankles because that's what I study, but being somebody who has chronic ankle instability, I know there are certain activities that scare me to death. There are certain activities that I want to avoid completely because I know what it's like to re-sprain my ankle. I know what kind of a setback that can cause me. So I think if we dive in deep with a lot of these patients, I think we can find out those specific fears and those things that are holding them back from, having a fulfilling, physically active lifestyle.
Yeah. Kind of going off of that, one of my other questions was, there's many obstacles that can have to be overcome during the rehab process of fear avoidance. And one of the ways is, getting back into that return to play. Oftentimes, if it is a sport that has equipment involved, you start getting that back in. Like I mentioned, like, you got to start, if you're a soccer athlete, you're going to start throwing in some different drills, and that might be what's causing someone's fear. So from your experience and your perspective, do you think it is better to tell the athlete what you're planning to do, or do you think it's better to just kind of throw it in the functional return to play, mimicking what they would do in a gameplay situation, or let them figure out and kind of see, how it goes mentally with, like, if they're being told what they're going to do, what to expect, or just throwing it in?
I think both of those things, but I think it needs to work on sort of a progression in terms of what you throw at the patient. I think that early on in our rehabilitation, we need to focus on very clear, almost sort of planned, choreographed type of maneuvers that, it still creates a little bit of, variability if you're doing a balance type task or a functional movement type task, but making sure the patient's completely comfortable doing those things when they're anticipating actually doing them. I think one of the limitations that we have with rehabilitation is I think that, in a lot of cases, we stop that progression before we've had a chance to fully address, whether it is dual tasking, whether it's unanticipated tasks, and some of these things that I think can really help address fear avoidance. I think sometimes we cut those things too short. So when we're doing rehabilitation, once we've mastered some of these anticipated tasks, we have to get to a point where now we're throwing in distractions. We want to make this as close to a game situation as possible. And we don't want our patients focused on the position of their knee or the position of their ankle during a game. We want them focused on the environment around them. What's every other player doing? Where's the ball? What's the instruction coming in from my coach? And we want all the stability of their extremities to just happen automatically. That's the whole concept of neuromuscular control. But I think a lot of cases for rehabilitation, we don't get to the point where we're fully focused on that. And I think doing things like throwing in dual tasks, whether it's completing 2 physical tasks at once or throwing in some type of cognitive load simultaneously. I think doing unanticipated tasks where you have a couple of options, where you're basically reacting to your environment, I think that's really important for building that automaticity of these tasks and the neuromuscular control that goes along with it. And then I think some of the external feedback pieces too, where we're training people to properly position their bodies in space. And in order to do that, we need to make sure that they are stabilizing while focusing on their external environment. And some of these feedback cues can help us build that. I think another limitation for, fully attacking the fear avoidance issue is the assessment piece of it. We know that big limitations for patient-reported outcome usage exist in the athletic training world. And we know that generally speaking, athletic trainers are not very good at using patient-reported outcomes. It's a very low usage rate among these clinicians. And we know for a lot of reasons why. We know that time is a huge obstacle that athletic trainers have, particularly in traditional settings, K through 12 and college athletics. We also know that knowledge of these instruments is limited. Not just knowledge of fear avoidance instruments themselves, but even just knowledge of how to implement a patient-reported outcome. When I have this form, what exactly do I do with it? How do I introduce this into the the recovery process with a patient? How do I instruct a patient on how to do that? I think all these little things that sometimes get taken for granted. We've seen this a lot with our ankle sprain research, where we survey athletic trainers about doing assessments that we think are pretty easy, pretty standard, very rudimentary type stuff. And a lot of athletic trainers don't feel comfortable with it for one reason or another. And so I think that, making sure that usage of these PROs is an integral part of education, making sure it's an integral part of continued education and workshops. I think that athletic trainers need to learn how to implement this stuff. In terms of the time barrier, we know that exists, but there are ways that we can, mitigate some of that issue. I know if you look at some patient-reported outcomes like the TSK, there's been efforts to reduce the number of items within there. TSK has gone from 17 to 11 items. So we know that we can implement a version of that PRO in a shorter amount of time. So it doesn't fully eliminate that time barrier, but it does help curb it to some degree. So just other things to think about besides even just the rehabilitation to address it. I think, the assessment piece is equally as important.
Right. And even after you complete one of these PROs, being able to understand what your results mean too. That's the thing. It's easy to, implement one of them and think, okay, yeah, I'm using this, generally look at it, but then actually being able to dig deeper, understand and make connections between where is this actually stemming from? What can I do to address this? That's a thing too, because if you don't know what you're seeing, what the results mean, how are you actually going to combat the issue in a way that's going to be meaningful for the patient and impact how their rehab can be done, different ways to go about it in that sense too.
Yep.
Another thing was, we kind of touched on it a little bit, trying to get athletes to not focus on what movements they're doing and trying to distract them away from the injury. Do you think that, well, we know it's been studied that it can lead to more injuries. How would you go about combating that issue of trying to get them to just focus on swiftly going through the movement rather than focusing, say they have an ankle sprain, on trying not to move in a certain way to re-injure themselves and just actually getting back into the return to play?
Yeah, I think some of the things I said before, I think unanticipated tasks are so important. Using combinations of movements that are directly related to their sport. I think multi-segmental, multi-directional type movements that involve changes of direction, a lot of eccentric loading from like landing from a jump or making a cut. I think all of those things are very important for athletic populations. Like I said before, I think that when you introduce those activities into rehabilitation, we need to do it very anticipated so the athlete knows exactly what they're doing from the get-go. But gradually, as they become more comfortable with those things, we need to include those into more of an unanticipated setting. Now, those can be tricky because then it creates a lot of new work for the athletic trainer themselves. There's a lot of creativity that goes into rehabilitation. The good thing is, I think that's one of the things that athletic trainers really like about their jobs is they can get creative. How do I implement a balance task and counterbalance that with a jump landing task to make it unanticipated, where they're supposed to have a more of a stability reaction versus more of a plyometric reaction. How can we do that to make it as complex as possible? Can we make that multiplanar? Can we make that multi-directional? There's ways that we can do that, but I think we don't get to that point until they feel fully comfortable with the anticipated piece. But then even once we get to this unanticipated piece, I think we need to keep hammering away at that until the athletes feel comfortable in those tasks. I think so often our assessment of patients going through functional rehabilitation is not, fully objective or even subjective. I think a lot of it is, I did this rehabilitation with my patient, therefore that's my evidence that they've restored that particular function, right? Like I did 2 weeks of balance training with my patient, so their balance must be improved, right? That's sort of my inference that a lot of athletic trainers make from their rehabilitation. But we need some type of objective criteria for that. And so for me, at minimum, I think you got to look at, for lower extremity, that's my area of expertise. You got to look at, some of your hopping tasks, like a triple jump or a single leg hop for distance. I think you can look at a landing air scoring system, star excursion balance test. Those are all valuable tests of balance, neuromuscular control, power, etc. But then I think you look at those in conjunction with some of your fear avoidance beliefs and your kinesiophobia and your self-reported function. If you ask your athletes to answer some of these questions in relation to some of those tasks, are they indicating that they're feeling comfortable with them? That being said, though, I still think there's limitations even with those tasks that I described, because all of those are completely anticipated tasks, right? We don't really have good objective criteria for a cognitive return to play, right? Where our patients are receiving cognitive loads and unanticipated tasks. Those tests just haven't been very well established or even developed within athletic settings. So I think that there's a huge need to develop those.
And another thing is, sometimes it can be tough too with the chronic injuries, chronic ankle instability, that we have the patients that there might not have been, there's not something acute traumatically that really caused it, but it's just an overtime kind of thing. And the patients just overall don't feel stable with what they're doing. So what has your experience kind of been with that? Do you feel like it's a bit harder with the chronic injuries, or more of the acute that has that traumatic onset where they're trying to combat getting back in without having fear that, it caused so much trauma mentally that that's going to happen again? Or is it just the overall instability because they can't get over this, the strength, nothing's helping, it seems to them, to the patient, to get them back?
Yeah. My perspective on this, and this is totally my personal opinion, is that it's the acute injury that is causing the fear avoidance. There might be some data out there, some empirical evidence that says acute versus chronic causes more. If it is out there, I honestly don't know what it says. I just know from my experience, both as a clinician and both as a patient, that it's the acute injuries. From my earliest experiences, having ankle sprains, having traumatic knee injuries before, those memories stick with you for a long time. That pop and that pain that goes along with those acute injuries, those will stick in your brain for decades after the injury, and you'll do anything you can to make sure that doesn't happen again. So from my experience, that's always been my my motivation to avoid certain tasks, is to avoid more ankle sprains and knee sprains. I've had plenty of chronic injuries, nothing super severe, but tendinopathies and impingement in the shoulder and stuff like that, and those aren't fun at all, but they haven't made me scared at all. But then even from dealing with patients as an athletic trainer, I can't think of anyone who's indicated any intense fear over chronic injuries. From my experience, it's always been the acute ones.
Gotcha. And so some experiences I've had, I mentioned, soccer, I've had some in football too, with just more of those acute injuries. Sometimes the chronic, but more so just the frustration of it feels like nothing's working. They're just trying to do everything they can to return back to their full potential. But to how much extent do you feel that can relate to the trust that an athlete has in their athletic trainer, with having this fear, but trusting that their athletic what they're going to do is not going to put them at further harm during rehabilitation? One thing I could think of is with the soccer athlete, it was a new athletic trainer for that season. And so the athlete wasn't with this athletic trainer during the injury that they've had throughout the previous seasons. So you could tell that they weren't as trusting, didn't fully understand. They kept questioning the athletic trainer, like, why are we doing this? Why are we doing this drill? Is this going to hurt me? Asking questions like that, as compared to some more traumatic injuries that have happened in football where they've had the same athletic trainer for their all 4 years. And so in the situations you think where they're going to be a little more hesitant in returning to play and have that fear avoidance, I've seen it sometimes come down to trust. So I'm just wondering what your perspective is on that.
I think trust is a huge issue, and not even for fear avoidance, but for confidence in all parts of your recovery. I think that having trust in a clinician who's treating you is incredibly important, and it goes to the buy-in, I think, of the patient. I think a patient who thinks they're working with a clinician who's on top of their game and leading them in the right direction, I think they're more likely to follow that individual down that path. I think we've all in our personal lives been exposed to a clinician of one type or another that we probably weren't that crazy about, and we weren't sure if they were on top of their game or giving us the best advice. And I think that people who see that are less likely to go and work with that, whatever the game plan is that's been laid out for them. I don't have specific empirical evidence of that. I think it's a little more intuitive, but I think there is absolutely some personal experience that I've had where, I've seen, patients work with athletic trainers or other clinicians that I don't think they were confident in. And I think it clearly affected the way that they approach their own rehabilitation.
Another big topic that has come up a lot is the idea of role strain as it is related to fear avoidance after injury. So do you feel that those who have their role in their sports has more value to them are more willing to overcome that fear? Or do you feel that they actually have a harder time because they want to come back at their full potential and not return too soon after an injury?
Yeah. So are you saying that if somebody has, say, for example, a starting position or sort of a coveted position on a team that, are you saying they might want to rush their return to sport, or are you saying they might want to be more careful with it and make sure they're returning at optimal level?
Yeah, seeing which way they kind of fall on the spectrum.
Yeah, that's a great question. I think you probably can get both mentalities. If I had to guess from my own personal opinion, I'd say there's probably more urgency to get back faster than there is, more safely. But yeah, I don't know if I could say either one for sure.
Right. Okay. Yeah, no, that was one that I've seen varying perspectives. So I was just kind of seeing any thoughts on that one.
Sure.
I think both can be understood equally. There's some that are like, I need to get back, so who cares what happens as long as I'm back, and the other ones are like, I don't want to rush it, I want to be back when I'm at my full potential.
Yeah. And going on top of that too, I would also say that other stakeholders come into play with that too. I think parents are a big one, especially if you're dealing with high school, middle school athletes, and I have definitely seen that go both ways, because I think the parents are usually more interested in speaking their mind and just being very straightforward with you. And I do think that sometimes parents get a bad rap because there are a lot of them out there who are very pushy, and they will push to have their child return to play as fast as possible for seemingly or forgetting seemingly any possible risk associated with that. That being said, I think there are also plenty of parents out there who are on the exact opposite end of that spectrum, and many of them are very conservative in terms of their approach to their child's health care, and they will not want their kid to go back to play until they are 100% sure that everything is ready to go. So I think we probably spend more time talking about the parent who is more aggressive in their push for their kid, but I think that you can see plenty of the exact opposite end of that spectrum too.
Yeah, that was kind of going off my next question too, is just about, different age groups and settings where we see this too,
Mm-hmm.
High school compared to college or professional. Where do you feel that fear avoidance becomes where you see it the most based on different levels and age groups?
That's a great question. I definitely don't know where the research is with that question. And to be honest with you, I don't know that I've worked with enough variety of patient populations to say that it's more college versus pro versus high school or whatever. I did some graduate assistantships working with college athletics when I was a master's student, but since then it's been mostly high school populations. Which I do think there is fear avoidance that goes along with those. But again, like any population, I'm sure it's a range. You get some that it affects more than others. But in terms of looking between different demographics, I don't think that there's, or at least I don't know of any disparity between different groups like that.
Yeah, kind of like what we talked about with, parents coming into play more so at the high school level. That's kind of what I've noticed, is that at that age, when you've got an athlete who isn't totally sure about returning, it'll be like, well, my mom's a nurse and she said this, or my dad's a PT, and different answers like that. Where at the college level, otherwise, some freshmen might still have that approach, but when you get to juniors and seniors in college, they're on their own, they're thinking their own type of thing, and sometimes they're focused more on just, like I said, role strain, and they're just ready to get back and might not think about that as much as those who still have those outside influences coming into play in different perspectives of stuff like that.
Yeah, I do think we think a lot about it in terms of, some internal characteristics of the patient. They're this years old, they play this sport, they're in this grade level, or, this year of college, and, what about that is really affecting their fear avoidance. I think there probably is some some truth to some of the external influences of fear avoidance, though, and I think it maybe at least indirectly equates to some of the pressures that athletes have to return to play, whether it's self-motivated or whether they're feeling it from a parent, a teammate, a coach. I think those factors are absolutely they exist, and I think that that goes back to some of the trust issues that maybe an athlete has with an athletic trainer. Are they gonna go through the full rehabilitation if they don't really feel like the athletic trainer is taking them the right direction? I think all that stuff is really important, and we've seen that in other studies. Some of the the psychological profile of an athlete or a patient is absolutely affected by these external factors. You can look at assessments of things like resilience and self-efficacy for rehabilitation, and we know that those are influenced by external forces, and we know that when those external forces are supportive of things like rehabilitation and full recovery, there's reason to think that athletes or patients are more likely to carry out that full recovery plan. Whereas those who are not feeling supported, they're probably feeling more pressure to return to play and to fulfill the expectations of all of these other stakeholders that around them, and I think that their own values kind of get pushed to the side.
Right. Yeah. Another thing I had experienced is my rotation with men's soccer. We have a lot of international students, and so kind of going back to the idea of trust, a lot of them didn't even know what an athletic trainer was. And so early on in the season, when they have a lot of injuries, either traumatic or just, a hamstring strain, and they just feel like they're not recovering, but maybe it's because they're not attending rehab times and stuff like that. We found that it really does fall back to that level of trust and seeing, do you know what an athletic trainer is here to do for you? Or a lot of them came in, they would have still at the freshman level, we had a lot of parents, communicating, and they'd say, I want my child to go see a doctor. And we had to have that conversation of, while we're not a doctor, we still have the sound judgment to make this decision, and we know what we're doing for you. And so that came to a problem too, is then also if the athlete is not speaking up and saying, I don't know how to do this, I don't know what I'm supposed to do, then they're not going to get the care they needed. And then as it's pushed off, it can lead to more fear because they don't feel that they have someone that understands what they're going through.
Right.
So that was a lot that we've noticed as well. But kind of one of the last things I wanted to talk about was what you think is needed in the curriculum to really get new grad students and athletic trainers to focus more on this belief in the model of fear avoidance. If we should have more of an implementation of, patient-reported outcomes, or how we should kind of get more of the focus on this.
Yeah, I think there's clearly a need for it in the curricula. I think there's plenty of evidence of that. That said, it's always tricky. Anytime there's something new that needs to be evaluated and accounted for within recovery, it's one more thing that has to be put on the schedule. And it's like, well, we already had all these other things on the schedule that are also important. Where's this new thing fit in? How can we, bring it into the mix to the point where the students are now proficient with it, or at least comfortable with it? That always becomes tricky. And I'll admit from some of my classes, it can be tough to fit that stuff in, because I do think that some of these concepts get a little bit more complex and maybe even a little bit more abstract compared to what athletic training students maybe expected to hear about, or what they're used to hearing about. I have a hard time sometimes in classes getting to these more advanced points that I want to get to. Sometimes you do get stuck working with students on, we got to make sure we know what an isometric contraction is. It's really hard to understand advanced rehabilitation concepts if we can't get too far past, what an isometric contraction is. So sometimes that can be a barrier to implementing these things, and you get so stuck on making sure that the basics are fine-tuned that you lose some of your ability to advance to those more complex concepts. That being said, in terms of how to implement it, I think that there needs to be a clear discussion, number one, on some of these psychological aspects of injury and almost looking at them as unique impairments that can arise with a given injury. Same way we assess strength and range of motion and pain, we should be assessing self-reported function. We should be assessing kinesiophobia or fear avoidance and then addressing them accordingly. So I think the same way that we teach goniometry, the same way we teach manual muscle testing, we should be teaching teaching students how to implement a patient-reported outcome survey. How do they put that into their evaluation? How do they take data from it, and how do they use that data in order to put together a comprehensive rehabilitation plan? So I think the same way that we implement those things, I think fear avoidance needs to be a part of that. For the rehabilitation piece, the same way, we discussed earlier about how do we go about actually improving our approach towards fear avoidance, I think some more of those advanced rehabilitation concepts related to dual tasking, unanticipated tasks, external feedback, making sure we're getting to that point where we are, mimicking the functionality of their sport as closely as we possibly can within our rehabilitation clinic. That way it makes that transition from the athletic training facility to the field that much more seamless. And I think that we have less, or we're less likely to experience that fear avoidance if they have a big jump. We wouldn't take them from doing an isometric contraction to doing complex plyometric drills, right? But I think more often we go from doing, maybe just isotonic strengthening and single imbalance to okay, you're good to go. You can go on the field and you can go, play in a football game. That's a huge jump right there. And so if we're not making that a very steady stepwise progression, I think we can hurt that. So I think that has to be a part of our education for students, is making sure we take that advanced rehabilitation piece as close to reproducing the sport as we can.
Right. And that's, a lot we talk about here, obviously the disablement model too, and actually thinking about the person as a whole, like you said, different sports that are in, different roles they have, different internal and external factors, really important. And actually using that idea of patient-reported outcomes as being a step in your treatment and evaluation process, rather than just, focusing on, okay, you take a history, then you go palpation, just following that down. You need to include those patient-reported outcomes in there, which I think gets lost along the way a lot of times, where it's brought up or, it's said PRO, and, some students may have a better understanding than others. But if it's not explicitly taught and understood, then those who don't have as better of an education on that might not be likely to implement it as more than others. But yeah, that was kind of where I just wanted to get an idea of just experiences you've had, thoughts, and kind of next steps. So just seeing if you had any other final ideas or perspectives to add in.
Yeah. I think another thing to keep in mind too is that if you're really looking for, just more evidence that these concepts of fear avoidance are important and need to be addressed, keep in mind that a lot of these fear avoidance questionnaires, they also have direct associations with, other clinician-based impairments. So if we look at things like strength, if we look at things like movement kinematics and balance, we've seen that increased fear avoidance is equated to reduced performance on these tasks. So if you want any more evidence that, working on these things can also equate to, some of these impairments that athletes and coaches are probably more hyper focused on, I think that's a pretty good indication of that. So I wanted to make sure that we talked about that. I'm trying to think if there's any other major concepts that I was forgetting. I don't think there are, but I really like the talk. I think that your questions were really great, and I'm glad that y'all are doing this for your program. I think that even just talking about this and sharing some of the conversation, I think is really helpful to make sure people are keeping this fear avoidance issue on the front of their mind.
Yeah, and that was definitely my goal. I just wanted to bring this more aware to people who aren't thinking about that, or, might have situations where athletes aren't progressing as they should, or they can't understand, why they're not able to get to the next step. And so bringing the idea of fear avoidance might be able to help answer some of those questions. As I mentioned, some might not have the same education as others in the sense of how much it's talked about in classes. So I really appreciate your perspective on everything. It's going to be great to share with my classmates, other people in the program as well. So I thank you so much for your time. I appreciate it. So I will share this. And thank you again. Have a great rest of your day. I'm going to stop recording now. So.
Sure. All right. Yeah.